Any patient with coming with an in-toeing, it can be because of femoral anteversion, internal tibial torsion, or metatarsal adductors. Anyhow, any patient with coming with in-toeing would means that the patient is having angular deformity. For that, I would need to have a Staheli profile, which consists of foot progression angle number one, number two, a Craig test, which is lying the patient prone and um, um, positioning the leg into a level when the retrocater is more prominent, and that angle which is subtended at from the horizontal from the vertical line is called a femoral anteversion angle. Then is tibia thigh foot angle, which helps me to check the tibial torsion, which is 5 to 20 degrees. And then is the foot bisector line, which helps me to identify metatarsal adductors. Mostly metatarsal adductors happens in infant, intertibial torsion happens in toddlers, and femoral anteversion happens in more growing population. In towing, we do not do operative intervention most commonly for in towing, as with the age and the passage of time, it does improve. There is it's twice as frequent in girls than boys, and the positioning in a W position is one cause of such deformity. Uh, So for femoral anteversion, it resolves spontaneously in about 80% of the population. If there is a deformity, I would prefer to do a CT scan and do a derotation osteotomy, which can be at the subtrochanteric as well as the sub supracondylar levels. Anterior tibial torsion happens in the toddler. It's also self-remitting up to 4 to 6 years of age. If the child is more than 10 years of age and still there is deformity, we can do a supramalleolar osteotomy, which will supramalleolar osteotomy. Prior to doing the osteotomy, it should be noted that there is a more risk of compartment syndrome, so I'll go on for fasciotomy first. For metatarsal adductors, it is associated with DDH. A Bleck's criteria is or grading is identified. A normal is when the tangent line is between the second and third toe. If it's crossing the third toe, then it's mild. If it's between third and fourth toe, it's moderate, and if it's between the fourth and fifth toe, it is severe. The operative intervention in the treatment should be conservative with stretching and manipulation and casting application. If more than 4 years of age and still there is deformity, we can go for operative intervention in metatarsal adductors. The release of abductor hallucis and medial capsule is advisable. In resistant stages, a lateral column shortening or medial column lengthening is advisable.